Hi, good evening, good morning, good afternoon, everybody, wherever you are. A very warm welcome to all of you to this post IMS 2023 by the International Academy for Clinical Hematology. I'm Mohamad Mohty from the Sorbonne University and Saint-Antoine Hospital in Paris, in France. And it is my great pleasure and honor to be your host and moderator today. I don't think I need to introduce this kind of activities now. You are thousands of people following the IACH activities across the globe, and you all know very well that after every big key meetings in the field, uh, whether it is the general global meetings like ASH, IHA, EBMT, or whether there are disease-specific meetings in myeloma, lymphoma, CLL, Waldenstrom, we would organize always a sort of a round table with the top experts who actually would debate, digest, and summarize maybe the state of the art for all of you. And this has been really very highly ranked, I would say, by our audience, and this is extremely popular. So for today's roundtable, this is about the International Myeloma Society annual meeting that was held in Athens, in Greece, earlier in September, 1 month ago. And it was an amazing meeting as usual. Our Greek host did really a fantastic job, but also the scientific committee also has put together a very comprehensive, state-of-the-art, high-level educational program. It will take us hours actually to go through everything, so I'll try to structure the discussion on some key and hot topics, I would say, with our distinguished faculty today. And we have already on board, I think you can see them on the screen, Dr. Meral Beksac from Ankara in Turkey, Dr. Suzanne Lentzsch from New York, Dr. Hira Mian from Hamilton in Canada, Dr. Irene Ghobrial from Boston in the US, but she's actually now, I think, in New York City. You can see the yellow taxis behind her. And this is broadcasted live, by the way, guys. It's not pre-recorded. And we have already connected Professor Thierry Facon from the University Hospital of Lille. We will have during the roundtable, hopefully, he will be able to connect Dr. Luciano Costa, who is flying or landing at this time. And last but not least, I'd like to apologize on behalf of Dr. Mateos, who could not make it this evening. And that was a last minute issue a couple of hours ago. So thank you, Suzanne, Meral, Hira, Irene, and Thierry for joining us today for this roundtable. And I would kindly remind our audience and all the colleagues that, of course, you can interact with us. You can send your comments, post your questions, and suggestions, and I'll do my best to share them with the faculty. So I'll try to be very simple today, and we will not reinvent the wheel. So we will discuss things the usual classical way, frontline therapy for the transplant eligible, non-transplant eligible. We'll discuss relapse with a special focus on immune therapies because we know that they are really making a huge difference in the life of many patients. But also, I thought if we have some time, we will discuss a little bit about what's ongoing in amyloidosis, although it's a rare disease, but the prognosis has been improving dramatically in the right direction over the last 4 or 5 years. So thank you all for joining. Welcome. And my first question to the panel, and please feel free to jump in during the discussion or to ask questions to each other, guys. When it comes to the transplant-eligible patient, I think we all know it's about induction, high-dose chemotherapy, consolidation plus or minus, and then maintenance. And I think each step of this process is currently undergoing some key or important changes. So for induction, what would be the consensus for today, and where do you see the future? Is it about triplet VRD, bortezomib Lendex, or DARA VRD, DARA VTD, quadruplet? Where do you see things, and how can we improve over these options? So who wants to start? Ladies first. I can see people smiling. Shall we do it by alphabetical order, Professor Beksac?
That's okay. I can, go ahead, and start. I mean, I'm talking about, how we approach that at our institutions. And I think the Griffin data were really strong and showed that the quadruplet, is superior to a triplet. You can argue we only have PFS, we don't really have overall survival. But I think with the life expectancy of our patients, 10 or even more years, it's very difficult to really pinpoint, what is the effect of the initial treatment when patients later undergo several other treatments. So I'm not sure whether that concept, of really looking at overall survival as the only marker for success is really true. So the PFS and the higher rate of MRD, longer PFS, higher rate of MRD, convinced me to give for transplant-eligible patients a quadruplet, and that is DARA VRD, or in high-risk patients, DARA KRD, especially also in younger patients. So just to open the discussion.
No, I like this. What do you think, Irene?
Well, I totally agree with Suzanne, and the problem is we're all women, so we're going to agree rather than disagree here. But I would just say that overall survival is going to be very hard to prove anymore in any of the upfront trials of multiple myeloma. And we just have to be able to agree that MRD should be an endpoint. And unfortunately, the FDA is not willing to take it yet, but we're hoping that indeed the MRD will be an endpoint that we can measure as a surrogate for overall survival. For now, we just have to try again and see if we can use it. But totally agree that the depth of response, the progression-free survival that we're seeing, and the lack of extra toxicity other than infection indicate that 4 drug regimens is the way to go for our patients.
How is it in Canada, Hira?
Sure. So, we had a fantastic session at IMS on the newly diagnosed, and I think, saw the Smani presented again, the need for quads. But then I think Dr. Rajkumar brought us back a little bit and showed us that with RVD, transplant, rev maintenance, Emory's data again shows overall survival of 10 years. Canadian data again in standard risk patients with a triplet regimen, transplant and single agent maintenance, you're getting survivals of 12 to 13 years. So I would entirely agree with Suzanne and Irene that, we definitely want to do quadruplets, and, there's more and more emerging data to show deeper responses. But we really, I think over the next few years want to decide, does everybody need a quadruplet? Do you need, DARA in the maintenance setting as well? So lots of questions. And then I think, again, Dr. Rajkumar brought up at the a point about the cost as well with some of these therapies. So lots for us to consider. And I guess the other part I'll just throw out from, one of the key messages from the IMS meeting, certainly for high-risk patients, and then the concept trial was presented with ISA KRD, deep rates of MRD negativity, both again in transplant eligible and ineligible patients. And that's certainly a patient subgroup where quadruplets and as much as transplant is needed.
Okay, so here we have sort of.
Can I push a little bit, since we're going to have some counter, discussions? 10 to 12 years in myeloma is not good enough, especially if people are young and healthy and want to live. In fact, our hope would be cure and complete remission forever, and maybe not even maintenance. The hope for us to say is that we have cured patients and they're off therapy and they're living their life as a normal life. And if we are content with just, having 10 to 12 years and having them on maintenance therapy forever with the toxicity of maintenance, then we will never advance beyond that.
Point well taken. Dr. Beksac, in Turkey, how is it?
Well, I think during the IMS meeting, the role of quadruplets, especially in the setting of high-risk disease, has been underlined quite strongly. And the concept trial has just been published in JCO now. And it is very important to note that the definition of high risk is a very slippery field now. And for instance, the role of 1Q, 3 copies versus more than 3 copies, and also looking at the optimum trial from the UK, and having the Sky 92, the gene expression profile, and the fish having a weaker role in defining high risk versus a gene expression profiling. So these are issues, I think, that warrant, in my opinion, to have one type of treatment which is the best for all patients. And if you look at the concept trial within the high risk, its results are very good in this unmet group of patients. And if you look at the Cassiope, and even in the Griffin, the difference between high risk versus the standard risk is not overcoming the high risk, even in the fish-defined category. So we still have space to improve. Quadruplets are the answers. Which quadruplets? I would like to hear the opinion of the faculty in terms of carfilzomib versus bortezomib. This is a very, very important discussion, I guess.
So I was about to be the devil advocate, because I hear a lot about the issue that if it is high risk, maybe a quadruplet should be there, and even carfilzomib instead of bortezomib is better. What is the strength of evidence actually we have for this? Maybe we have a gut feeling, but is this sufficient to do this? Although I appreciate that in terms of peripheral neuropathy, carfilzomib is going to do better than bortezomib, but I don't know who want to take this. Suzanne?
Yeah. There are some studies and publications in which literature was summarized. For instance, one study is from Dr. Chakrabarty, in which he determined the hazard ratio for patients receiving, carfilzomib, for instance, in the Forte trial, or daratumumab, and it shows, the trend is, that in high-risk patients, more is better. Yeah, so Dara makes kind of, a difference. Patients with Dara and high risk do better, as shown in the Cassiopeia. And then also carfilzomib is better than bortezomib, in those high-risk patients. There are no randomized studies, I totally agree, Mohamad, and it's a summary of data what we have. But I think the trend, what we see more and more is that the more is better. I hate to say that. And I just want to go back. Meral mentioned already the optimum trial from Martin Kaiser from the UK. He even used 5 drugs. Remember, it's Dara, Revlimid, Velcade, cyclophosphamide, dexamethasone. And what he did, and I think it was very elegant, he said, how can I do compare my data, whatever I have as a result? So he said there's no standard for high-risk patients. So he took really a matched patient, I would say matched patients, also same high-risk cytogenetics, same methods to determine high-risk patients. And he compared his data with Dara RVCD versus patients from other myeloma trials from the UK, receiving, for instance, Dara VCD, for instance. And then he showed that, in more intense treatment with 5-drug regimen, patients do better. Of course, the issue is always, even if we have a 70% CR rate, how long does it kind of, last? Yeah, go ahead.
So maybe, Thierry, you would like to comment on this, because our cooperative group, the IFM, decided in the
Yes.
young and fit patient to go to for everybody with isatuximab, another anti-CD38 monoclonal antibody, carfilzomib, Lendex, ISAC-KRD, and then the risk would be evaluated in a dynamic fashion based on MRD. So maybe a comment on this approach, because you've been, it took us several years to design this protocol. So.
No, thank you, Mohamad. Just to let my good colleagues know, you have to know that Mohamad is a chairman every day, so, or is a moderator every day. So yesterday he was the moderator of an IFM session, exactly on the same topic, in fact, and so I can tell you what is, in a certain extent, the IFM consensus. So we basically say that there is a global agreement for daratumumab in combination with VRD in outside of clinical studies. And there was a discussion on 6 cycles versus 4, followed by 2 cycles of consolidation, but that's something a little bit different. And so DVRD was based on the Griffin study, also based on the Cassiopeia experience we have, because in France DARA-VTD has been approved, and so basically we did the switch between the old thalidomide and the relatively not really new, but from thalidomide to lenalidomide. So we switched from DARA-VTD to DARA-VRD, and there is a consensus on this. Then there was a discussion on the carfilzomib versus the bortezomib for high-risk patients, and here, as mentioned by Mohamad, we have a very strange situation in our country, because the MIDA study did use 6 cycles of isatuximab KRD for induction, followed by MRD assessment. So that's as you know, the study design is well known. So in a clinical study, we did isatuximab KRD. In the real life, we do daratumumab VRD. And the other thing is that there is no approval for KRD. So the French consensus was to say that there is no use of carfilzomib frontline in France today. Then the discussion on whether the high-risk patient may receive carfilzomib versus bortezomib is a good discussion, but for you, as said by Mohamad, you could say that there is some evidence, but not a totally clear evidence. And so you have the question with carfilzomib is that you have now several studies, or I would say many studies, not designed for global approval. And so the picture is, from my point of view, a little bit confusing with these multiple studies, no clear approval. And you may also say that in the and you could say the endurance study was not a very good study, but anyway, the VRD versus KRD was not successful in the endurance study. In the front line,
I mean, sorry, Thierry, it was a very good study, but it doesn't allow to answer this question. This is what you are.
That's a good point. But and you could say in transplant ineligible, we did carfilzomib versus bortezomib, so the client study, which was a negative study too. So you could discuss that for hours on hours. I would say the only thing I can say is that we do not use carfilzomib frontline for transplant eligible patients, even for the high-risk patients.
But Thierry, you have the IFM 2018 study.
That's true, but you know,
very good result.
Yes, that's true. But you know, and here you go back to the cost discussion also raised by Hira. You could say that the cost of carfilzomib. So carfilzomib has no approval, and carfilzomib is much more expensive as compared to the old bortezomib. So I'm not saying we are this is good or not, but what I can say is just that there is no consensus for carfilzomib in frontline in our country.
Also not for high risk.
No, yes, also not for high risk.
So can you allow me to just make a sort of an intermediate conclusion here, because time is running and it's very exciting. And just to reassure, because we have also patients and families attending our webinars and they are available on demand, that the triplet like VRD is the backbone. This is the minimum, and it's a very good regimen. Ideally, we would love to have a quadruplet, and then the debate would be between first generation, second generation proteasome inhibitor, and there's no consensus. Is my summary roughly okay, guys?
Yeah, yes and no. No, because you have, as you know, DARA-VTD has a kind of global approval in Brazil,
Absolutely.
in the US, in Europe, etc. So you could say that this 4-drug regimen has a global approval. Then, if you don't have access to a CD38 in frontline, if it is not funded, of course you will go back to the VRD. But I think there is strong evidence that 4 drugs should be used if possible, from my point of view. Then you have this switch. Then you get a new issue. The new issue is that the lenalidomide versus thalidomide, so the DVRD versus DVTD, and then the discussion on bortezomib versus carfilzomib. But that's another. I would strongly push for, if possible, I would say that 4 drugs should be standard, in a way, and it has been recognized like this by the approval of DARA-VTD in a way.
Meral, and we'll close this part.
Yeah, I just want to briefly touch on the fact that in the Cassiopeia, those patients who did not receive DARA but received DARA later on did not do as good as those who received DARA frontline. So we all know this, and I think it's a strong evidence in favor of the quadruplet. And there's another study from US which compares the first line and second line use of DARA. And we know that if you use DARA in the second line, the benefit is less. So I think this is a good drug, and I think our forces should be directed to frontline.
Excellent. So that brings me to a question from Dr. Abe Bave, who's raising the issue of MRD negativity. So with all of these wonderful combinations, whether triplet, quadruplet, irrespective of what you choose, if you are able to achieve deep MRD negativity, and my guess maybe sustained MRD negativity for 6 months, are we already ready? Is it prime time to avoid transplant, or what is the opinion today?
Mohamad, I think the best part, the best way to answer this particular question will be just the MIDAS study, because this is exactly the question asked by MIDAS. So patients who will achieve MRD negativity at 10-5 after 6 cycles of a CD38 and KRD will be randomly allocated to either transplant or no transplant. So I would probably say that one good part of the MIDAS study is just that one. So I would recommend to wait for that, to wait a little bit more.
So I believe there is a consensus to continue offering transplant, and I believe it's a pity that Luciano is not yet able to join, because he tested this idea, although it wasn't a randomized one. Susan?
Yeah. I mean, I see a trend, especially in the US, that more and more patients say, they're not really willing, to undergo transplant. And I also see, and that's very interesting, a trend, with the transplanters who say, if the patient's in a complete remission and has some high risk factors, why should I really kind of, do this? So it's quite interesting that it goes 2 ways. I see still a very strong role of transplant in high-risk patients. There's no doubt that those patients need transplant, period. All of the studies have shown this. And when you look for the PFS, and OS, especially when you look for Paul Richardson's studies, his study RVD versus RVD plus transplant showed, that there was a benefit, significant benefit, much higher than in the standard risk patient for the high-risk patients receiving transplant. So we should not say, transplant is off the table. It still has a role and should kind of, be given in high-risk patients.
Yeah, and I'd love to bring up the point that if we're not going to do transplant, then CAR-T and the CAR-T26 will help us with that, because I think high-risk patients definitely need something beyond just their RVD. Even if they achieve MRD negative disease, we know that it's not sustained and they will come back. And I'd love to see us use immunotherapy earlier and earlier, because transplant is giving us just a higher level of tumor reduction, and the hope is that we can do that with immunotherapy.
Thank you, Irene. So all of you, you have mentioned the issue of high-risk cytogenetics or high-risk patient. And here we have a question from the audience, and I like the question because recently there was an IMS sort of a consensus on how to define high risk. How do we define high risk today? Who's going to take this?
Mohamad, it's not as you mentioned. There will an IMS consensus will be published or will be issued soon, and so the definition will switch a little, will be modified a little bit, and so there was a big discussion on the deletion 17p and how many cells we need to be qualified as a deletion 17p patients, and the abnormalities of 1p and 1q have been incorporated into the model in a certain extent, so that I think that will be helpful. That will not be perfect, but that will be helpful. That will be at least much better than the definition we have today with the 414, the 1416, and the deletion 17p.
And I think it's important to separate really the functional high risk, the early relapser, within 18 months after transplant or primary refractory, versus the true high risk cytogenetic patients. Deletion 1p also, gain of 1q, especially when they have more than 4 copies, and then the usual suspects, 414, 1416, and deletion 17p, which I think is, high risk.
So that brings me to a question from the audience we have, and I think it's an important one. And Thierry mentioned our meeting yesterday at the IFM, and there was like an overwhelming 100% consensus on this. Would you offer a second transplant for those guys with high risk, with, let's say, the right definition of high risk cytogenetics myeloma? Are you offering a second auto? Hira?
I can start off, and mostly because we do not have quadruplet induction in Canada. So in the absence of really good induction therapy based upon older data for a subset of high-risk patients, unfortunately, we're still doing tandem transplants. No, I don't know what the evidence, like the evidence of that and the rationale behind it in quadruplets, and especially as you move immunotherapy up front, there probably will not be a role. But I would say certainly in our setting, in the absence of good induction therapy, tandem transplant still, at least for us, has a small role in very high-risk patients, including plasma cell leukemia.
Is it the same in Ankara?
Well, I think that the high-risk definition, in my opinion, and I think what already Suzanne had mentioned, the functional high risk is a very important definition. Even if your patient is responding to VRD, and if you achieve a deep response prior to transplant, then the first transplant is already the first consolidation, and the need for a second transplant may be this matter of discussion. But if your patient is not responding so well, but has responded to the first transplant, so if you document that with the deepening of response with the first transplant, I think there is great value for a second transplant, regardless of your induction. So that should be the decision maker. But during the IMS, this was a debate, and we know that Herman Einzel and Michele Kawa, even they are now doubtful within the conditions, of course.
So my guess, Meral, that you are applying the dogma or rule that was set by the Michel et al. Paper from the IFM more than 15 years ago, that a second transplant may benefit those who achieve exactly. So since we're talking about transplant, we have a quick question here from Dr. Boni Falbo about the use of transplant at time of salvage. Assuming you have a graft and a patient who responded very well to first transplant, let's say for 5 or 6 or 7 years. So I'm not talking about 2 years. I know it's not relevant, but 5, 6, or 7 years. Would be a second transplant an option?
Absolutely, Mohamad. Absolutely. You will be surprised. I mean, in the US, we have, a lot of options, talquetamab, teclistamab, and CAR T cells. but there are patients who progress through immunotherapy. They progress, after or under CAR T cells and immunotherapy, and those cells are much more sensitive to chemotherapy, or real chemotherapy, especially once it comes to a point where they have extramedullary multiple myeloma, skin plasmacytomas, and very often I go to my transplant and say, do you have some stem cells left? And unfortunately, things have changed. I come from a time we always had, a kind of, 2 times 10 to the 6 cells back up, for whatever case. Now they don't do that anymore. And I always say, guys, why didn't you collect more cells? At least I could give the patient, I don't know, 6 more months, for instance. So it would be, not 200 milligram melphalan, maybe, 140 or 400 would give them a stem cell boost with better counts. Yeah. So, and I think in certain situations, absolutely, but it has to be in selected cases.
Yeah, totally agree with Suzanne. And we are not collecting anymore for tandem transplants, although there is a need or there is a use for those stem cells if you completely depleted your marrow and you're trying to, help that patient. So I totally agree, but unfortunately we don't have the space anymore, and we're stuck with saying most of us are not using actually those second cells that we're storing.
And we have a comment from a colleague, which I think well taken, that especially in the very young patient, we may wish to take into account the risk of later MDS. But for the sake of time, we will not dig deeper into this. Please allow me to move a little bit into the maintenance field, because this is, again, something of concern. We already mentioned, I think Irene alluded to the fact that our patients usually don't like this endless, until progression therapy. For the time being, the label, the approval, the state of the art is about giving lenalidomide maintenance. Where do you see the field going? And we have even questioned about whether are we going to use CAR T cells for consolidation and then wait and watch, for instance, or are we going to use sort of combinations like anti-CD38 plus lenalidomide for a limited duration, and maybe bispecific antibodies for 6 months consolidation, like sort of a relatively long long consolidation for 6 months, or short maintenance for 1 year, and then the work is done. I don't know. Plenty of ideas. So where do you see the future? Thierry?
As you said, we have too many ideas. so from my point of view, the big challenge here is regarding maintenance is to figure out what will be the approval pathway, because we have so many. So okay, there is an agreement. So the lenalidomide maintenance has been established several years ago. Then you have studies combining lenalidomide and CD38, lenalidomide daratumumab. Then you have you have maintenance having a PI, for example, carfilzomib, and then we got these bispecific antibodies, and you have several studies investigating either a bispecific alone or in combination with something different. So at the end, that's a mess, I would say. That's very, very complicated in terms, and I am curious. This is a question I asked yesterday. I was not the moderator, but I asked Philippe and Hervé and you. Okay, what will be in terms of if you look at ongoing studies, what will be the next study providing a clear approval for a different maintenance, something either lenalidomide in combination with something or something different? And so there was some kind of we said that possibly the next will be the combination of len on daratumumab, but this approval pathway for maintenance is a little bit complicated. It takes time because studies are often quite complicated. You have many studies having 2 randomizations, the first for induction, the second for maintenance. So you have to wait for a long time to get study results and potential approval. So I am a little bit confused about this landscape, and I expect that in a way that the len on daratumumab will be approved, And my final comment is that, you know, and because so then in the next part we will talk about the elderly. You know, you can use DRD as a continuous therapy, so which means that older patients may get daratumumab len for 100 cycles, and in the younger patient this is not possible. So you could say that would be possibly a good idea to provide this kind of maintenance, but many other options may be valid in the future.
I agree with you, Thierry. I think you're alluding to the issue that when it comes to maintenance, in theory, we have to look to overall survival. And given what we have just mentioned earlier, that can be a very, very long endeavor, I would say. That brings me to give a warm welcome to Dr. Costa, Luciano. I mentioned that you will be late, so good news, you made it safe and well. And so welcome, Luciano, for joining us. And
absolutely, thanks for having. I'm just arrived in Chile for a meeting, but I was sorry that I missed the first half of the activity, but glad to join you all.
That's okay, actually, because we are already at the level of maintenance. So what is standard of care maintenance for you, Luciano, after auto in a high-risk patient, knowing your results?
Yeah. So, you know, to be very honest, never.
You have to always be honest. Why you mentioned this? We are always honest.
There's never on the trajectory of a patient where I'm more scratching my head when it comes to post-transplant therapy, because it's extremely confusing. I think one thing that we have not fully embraced is the idea that in my mind is very clear, or becoming more clear, that maintenance does not exist as a separate issue. So there's not such a thing as a best maintenance for standard risk breast cancer for high risk that doesn't take in consideration what the patient has received for induction therapy, what the patient has received or not a transplant, and what level of response the patient has achieved. So for most patients, I default to len maintenance like everybody else. The patients who we treated with quadruple induction and consolidation and have reached sustained MRD negativity, we feel very confident in stopping therapy for those patients. For high-risk patients, it's very hard. The ultra high risk, we tend to do a combination, either IMID and the PI, or IMID or monoclonal antibody. But honestly, we do that out of our own insecurity. I think the issue with the 2+ high risk chromosome abnormality is an unsolved answer, and I think we know the solution to those patients is not continuation of any combination of doublets. So I think that's the perfect setting to introduce new agents, and I think that's where we need to go.
Thank you, Luciano. So you are in Chile, and we have a question from Dr. Salinas in Peru, actually about the role of MRD-driven maintenance. Is this something you use routinely in your practice, or other specific situations? And again, the question is to all of you guys, where you would adjust the maintenance regimen according to the MRD status, whether negative or positive.
So Mohamad, and I think Luciano is the one to answer that question, you know, but I just kind of, you know, you asked before, you said, you know, what role has MRD, you know, and how are we using it, and do we treat until we achieve MRD? I see that a little bit different. I really like Luciano's, you know, master trial. You know, it's really nice, and I think this is where we are going, or what we are doing right now. I think MRD testing really gives you a good tool to stop treatment, you know, for whatever reason, you know. For instance, if a patient responded very fast, you know, went into a kind of, you know, very early on into a remission, deep remission, and has standard risk cytogenetics, do you really want to treat that patient for 10 years with Revlimid until the patient has no counts? I think the MRD, without really having randomized trials, but I think I feel comfortable to have enough data to say, you know, if the MRD is negative 1, 2, 3 times, you know, have it on hold, you know, or stop the maintenance. I think this is where we are going. it helps me actually, and I can talk later about that for amyloidosis, because the concept of maintenance is not developed in amyloidosis. And remember, those patients usually have an MGUS, which we transplant, so they easily go into a CR. And suddenly we have Janssen, who started to implement DARA maintenance in amyloid. So do we really need that? MRD actually helps here, but I didn't want to distract you guys, going back to MRD and myeloma.
I totally agree with Suzanne. And I think the only way we're going to truly say, are our patients cured or not, is if they are MRD negative, sustained for years and years, let's say 5 years. And if we can achieve that, why are we keeping them on maintenance therapy? So I think the better drugs, and hopefully we'll get to immunotherapies, and not using them for a very long time, and then following MRD, we will be able to see that.
So let me be provocative, Irene. I mean, I'm an MRD believer, and it looks like all of us are MRD believers, but still, we're not able to convince, for instance, the regulators that this is a way to go. So either our arguments are not robust enough, or either there is another reason. Did I miss something there?
Well,
no, but I think
I think. Go ahead, Irene, please.
No, I was going to say the FDA is willing to take it if we have the data put together correctly, right? It's not lack of evidence, but it's the lack of the data put together correctly for them to approve it. And they said it again and again, and it's our mission to get that for them, rather than saying that the data is not true. So I don't think that there's lack of evidence that the data is true. It's just that we unfortunately have not put it together to give them enough to get it approved.
And I think I agree with Dr. Ghobrial. I think that the high bar of the regulators is to approve new therapy based on MRD as a surrogate endpoint for clinical benefit. That's a very high bar. But it doesn't keep us from using that information to modulate, to use the tools that we currently have to manage our patients. We do that all the time with protein-based assays. We do that with fish, right? We're just talking about how we handle patients with high risk or standard risk disease. None of those things went to a formal approval that I have this pathway for high risk that the FDA or any regulatory authority endorses. The reason why I feel so, comfortable using that information is really because the notion of continuous therapy is really from a different time when the therapies were not nearly as active as they are now. And I think it's fair to say in the era of quadruple therapy and transplant, we don't know what maintenance is the best maintenance, or any maintenance it helps. Some people might not be needed, and some people may not matter anyways. Of course I love the data we have for master, particularly for standard risk patient. But I really often quote with the Cassiopeia trial, right? For patients who got no maintenance or got a maintenance that did not have any benefit, those who received quadruple the induction and consolidation and achieve sustained MRD negativity, they have a wonderful outcome. And those patients are, the field that progress are often rescued. So I think we need to start walking down that path of continuous therapy for a select group of patients who have a more active therapy up front and meet some certain response endpoint.
So here, that brings me, and then I'll give you the microphone, Meral. Probably I agree with you, maybe with all drugs, you need long-term therapy. And today, there are trials using the bispecific antibodies. Smart drugs like ranatamab, for instance, are being tested, teclistamab, in the maintenance with or without lenalidomide, with or without an anti-CD38. And given their potency and efficacy, they may end up, giving us excellent results after like 6 months, and then wait and watch, or 1 year and then wait and watch until progression. What are the thoughts of the panel? And I'll start with you, Meral, because you raised your hand.
So I wanted to highlight the fact that MRD assessment is again under continuous development. And we started with -5 and -7 and now minus. So it's the level is increasing. But on the other hand, during the IMS meeting, the peripheral blood MRD measured the PRD, which is a new definition based on mass spec. It will make a great impact, I think, in future without digging into the marrow, a non-invasive method. If it becomes available with a reduced cost, then maybe we will be talking in broader sense, and maybe we will be able to talk about stopping therapy in a safer level. And I'm sure the authorities will love to stop therapy at some point. And if they agree on MRD as a stopping treatment tool, then they should be able to accept this as a approval and trial endpoint as well.
I would entirely agree, Meral. And I think, Dr. Mohty, if you ask us in the next 5 years this question again, I think it will be really routine that MRD-directed therapy for stopping maintenance will be standard of care potentially.
And you know what, keep in mind, there were several publications, especially by Francesca Guy and then also Bruno Pavia about circulating plasma cells. I mean, this is coming more and more. And once it is easier to really, I would say, select the first group of patients, that means as long as you have circulating plasma cells in the peripheral blood, there's no need to do a bone marrow biopsy. Maybe you saved, a couple of bone marrow biopsies already. And peripheral circulating plasma cells together with whole body MRIs, I think that's a pretty powerful tool.
Excellent. So
yeah, I totally agree.
Let's move now, because I know Thierry may need to leave a little bit earlier, to the so-called elderly non-transplant eligible patient. And hopefully there would be a little bit more consensus than the debate about the young and fit patient. But it's always good news to have many options and debate them rather than have only a single option, because one size does not fit all in myeloma. So I know the answer of Thierry is that Dara-Lendex is standard of care to everybody. So with this background, I would love to hear the thoughts of...
No, I would not say that. I would not say that exactly. I said yesterday that there is some kind of global consensus, at least in the IFM, that this particular regimen is a kind of dominant standard of care. I am a little bit biased, but I think when you ask many colleagues around the world, if they have access to daratumumab in frontline, which is not the case for many countries, many of them will say that this DRD regimen will be a standard of care for at least some years. And then, so that's the bottom line. And then you can say, okay, what should we do for the more frail? So you can go to some mitigation of the DRD regimen, and Hira will comment on this. And you could move to 4 drugs, and we will have studies for that, and you will have new immunotherapies as well in the future. So, but at least the bottom line seems to be a little bit more clear as compared to what we have for the younger patients. So that's my understanding.
I mean, the DRD, excellent backbone, and there's no question. But I have to say, Revlimid is usually not well tolerated in older patients. And I don't know, my 90-year-old is not doing that well with 15 milligrams of Revlimid. So I think we should really consider the concept of having 4 drugs, but lower concentrations, Maybe you can go down with your Revlimid to 10 milligrams and give a little bit of Velcade. I think that concept is a little bit under-evaluated, to have, a lower dosage, but spread it a little bit for the older patients.
And also maybe to replace lenalidomide with ixazomib, another oral drug.
Yes, but okay, I agree, and but okay, there is no approval for ixazomib, but I agree with Suzanne saying that the DRD is a kind of backbone regimen. So the DEX will be discontinued, or you could say that no DEX. The LEN could be 5. You have to you can manage it in many different ways, and but okay, this combination. What I like to say is that sometimes people say that the frail patients may just receive 2 drugs versus 3 drugs, but if you have access to a CD38, it's true that the safety profile of CD38 antibodies is quite good, and so I would not say that because of age patients will not receive a CD38, for example, but but you may have a discussion on the other drugs, so the very low dose lenalidomide, or potentially some PIs or other drugs if you want.
Yeah, but let's be pragmatic. I mean, when we had initially MP, and the biggest advance was the advent of VMP and MPT. And we said, well, they are really fantastic. Then we moved to RD, which proved better than MPT, and that was really fantastic, and the results were great. Then we had DARA VMP and DARA RD. So there's always a way forward, in my opinion. Now, the question to all of you is that, how are we going to improve? Because you're right, Thierry, in the Maya trial, we're talking about more than 5 years of PFS, 62 months, which is quite incredible. So assuming you are able in a 75-year-old patient to push it a little bit more until 7 or 8 years, you will go beyond the usual life expectancy in the Western countries. So we are really missing this upgrade of the DARA index, in my opinion. Now, how would you envision the upgrade? Bispecific, CAR T cells, frontline? I don't know. What are your thoughts?
I mean, Mohamad, I would say yes. Think about it. And again, maybe this is provocative, but bispecifics and CAR Ts could be very well tolerated in the elderly population. And maybe it's a one and done for a CAR T, where the patient will receive it and then will be done. So this may not be such a bad option.
And again, you talk about elderly patients all the way spectrum from fit all the way to frail. So you're right, for my 85, 87-year-old, DRD may entirely be enough. But when we're talking about this category of older patients, it's, for that 75-year-old, could we envision where we have something on with the DRD, but it's fixed duration treatment potentially that's still MRD directed, that gives them a treatment-free interval. So I do still think, again, that there's still lots of room to really, in this population, to fine-tune some of our therapies still much further.
So I of course, the more drugs you add, the more toxicity you have. But so we always, I think we tend to assume that, whatever the drug that we added last is the one that should go away first, and is often quite the opposite. When somebody starts facing toxicities, usually the first drug that I tend to compromise and let go is the steroid, then the lenalidomide. So my patients who have a very big troubles with toxicity, often they end up with single agent daratumumab, second, third year down the road. I think the challenge I think of this population that I see in clinic is, yes, the median PFS is fantastic, the median OS is fantastic from the Maya trial, but we still have a subset of patients with early failure. There's still a subset of patients with biological high risk in a frail patient, and those I think are a little bit challenging. We know frailty, of course, predisposed to toxicity, decreased dose intensity. So I think approaches like fixed duration therapy, like Hira is exploring in Canada, are absolutely fantastic, and we need to do that. And the other thing I think is, paradigm challenging is we have always come with this notion that I got a new drug that will work in 20-30% of people in fourth line therapy. Let's see if we can add to our backbone. And that has served our community well. But now when you have agents with the safety and efficacy profiles we have with the bispecifics, I think we need to let go of that chronologic hierarchy, as I call it in myeloma, and go by a merit hierarchy, right? And maybe start building on with that with that piece as opposed putting on top of data land, and exploring things like consolidation with those agents and stopping therapy as a way to mitigate, to both prolong response and mitigate long-term toxicity are, I think, very very attractive ideas.
Meral, you have raised your hand.
So I wanted to mention that in 2024, there will be 2 trials, hopefully presenting their data, Cepheus and IMROSE, on the backbone of VRD, the adding of CD38, isatuximab or daratumumab will be well known for those patients below the age of 75. So that fit category of patients. Are we going to improve their RD? We will see if that happens. And the Nordic and the European groups investigated for the frail group, ixazomib, and I think that's also a good option, and the results are quite promising. So that's why I wanted to mention earlier. So there is space to improve in the frail and also in the fit group. And the new studies which are now integrating the new BiTEs in the DARA RD backbone now, that will take more time to have response and some results. I think maybe at least 2 years.
Just to make it clear, we're not supposed to call them BiTEs because BiTE is a trademark. So these are the bispecific and T-cell engagers.
Okay.
I needed to make this comment. I agree with you. So the IFM Thierry is planning, or almost there, the bispecific frontline for the elderly and relatively fit, let's say, patient. Can you just a little bit expand on the rationale? And because I'm more and more a believer that if you have myeloma at age 70 or 73, 74, well, we have in hand today all the tools to get you a 10-year survival with 1 or maybe 2 lines maximum.
No, the first comment is to go back to what was said by Luciano and other colleagues. So the weak part of the Maya DRD, from my point of view, is that it's continuous therapy. So and that being said, you could claim that using either a bispecific or even a CAR-T strategy might provide an opportunity to discontinue treatment. So you may have a consolidation with a bispecific for a few months, or you may have a DRD induction on a CAR-T strategy and then just done. So that theoretically, these new immunotherapies could provide ways to discontinue in a clever way treatment. The other thing is that if you try to improve on DRD, okay, just forget the dexamethasone. So the dexamethasone will just be dropped anyway. But the first possibility is to add, and if you could say, I will take a bispecific, a CD38 and some lenalidomide, and I will do a better job. But and you have studies doing that currently in the frontline setting for transplant-ineligible patients. From my point of view, you have to be very, very cautious about the frail patients, because if you combine bispecific, the len and the DARA, you will generate adverse events, and my suspicion is that the frail patient will not, at least some frail patients will not do well at all. So the other thing is to not to move forward with 3 drugs, but just to replace either the len or the DARA. So you may go with the bispecific and the daratumumab, or you may go with the lenalidomide and the bispecific. And these strategies may, from a point of view, should be investigated. So you will go with only 2 drugs, but these 2 drugs will be quite effective. So my final comment would be to say that we do not know that much about bispecifics in the elderly and especially in the frail patients. And I would recommend to be extremely cautious in the development. And my feeling is that some ongoing studies are not very, very cautious, I would say. And because we still have much to learn about bispecific in all patients, but I would say especially in the older patients.
Okay, any other thoughts before we move to immune therapy?
I guess just to follow up on that, like we need studies dedicated to frail older adults, right? So lumping, like we're talking about transplant ineligible older adults, it doesn't make sense as a category anymore, especially when we're going to bring these therapies that are remarkable, that maybe potentially be fixed duration, may need different dosing schedules or intervals in frail older adults. And, one of the concepts I hope, we're able to further develop again is this idea of dynamic frailty too. So, if you're frail once, are you forever going to stay in that category? And could you potentially change how you escalate or de-escalate therapy as well? So I think it will be lots of exciting stuff for that subgroup of patient in the next decade.
Wonderful. Thank you very much, Hira, for this really important comment. So let's move now to the last part of this fantastic discussion. And again, I'd like to apologize for all the colleagues asking questions, and we're not able to take all of them. But I'm replying personally to each person, apologizing, or even providing the link to the website, to the relevant website where they can view this webinar again. So when it comes to immune therapy, it's about T-cell redirecting therapies. Let's call it like this. And it's about cellular therapies, CAR T-cells, and we've been discussing a lot about CAR T-cells. And a little bit more recently, we are fortunate now having the approval of different bispecific antibodies. And it's unbelievable that during the months of August, in the middle of the summer, at least for the north part of the globe, while everybody was on vacation, we had 3 approvals. The approval of elranatamab, anti-BCMA, the approval of talquetamab, an anti-GPRC5D bispecific, but also a sort of a variation of the approval of teclistamab, allowing to deliver it twice per month in those patients who are responding, because teclistamab was originally already approved. So maybe I would like to bring here the question, and this is about assuming they are all available. How are you going to make your choices? And actually, there is a poll now ongoing on Twitter, a colleague asking this question. So if you have a relapse refractory myeloma after 4 lines of therapy, you have CAR T cells, you have tecli, elranatamab, you have talquetamab, what do you choose and why? And that was discussed during IMS, of course. Suzanne.
So let's say we have everything available. I think the CAR T cells, I would make sure that the patient is fit enough. I saw a couple of patients going to the ICU. So I'm not sure whether I would give my 90-year-old patient CAR T cells. I hear very often there's no age limit, but I don't know. I mean, when I see the patient and I see the patient is frail and, might not do well with high fever, for instance, that can happen anytime. And I think we have the responsibility, if the patient is 85, do we take the last 5 years, maybe the patient wants to spend with his family, and we are really a Rambo here and kind of go ahead and give CAR T cells. So I'm a little bit more careful. And I think with bispecifics, we wouldn't have really that risk. I think they are relatively well tolerated. So the frailty, the age would help me to make a decision between CAR T cells and the bispecifics. And of course, right now we have teclistamab. We all feel comfortable with this. But I think the GPRC5D talquetamab are very interesting. And I think they're a little bit more selective. So what I expect is that because of the selectivity, you really eradicate less B plasma cells, the healthy plasma cells, and you might have less infections. So maybe I would favor, talquetamab over in the future, over teclistamab, especially in patients who have a history of infection.
But then here I can be the devil advocate, Susan, and say, well, on the other hand, probably with the GPRC5D directed bispecific, you have less infections according to the studies. They're not randomized, they're not head-to-head, but the numbers are lower, and maybe immunologically it's relevant. But then they do have some other annoying side effects. They are not life-threatening, but dysgeusia, skin toxicities, mucositis. We were just talking about the quality of life, that we have to pay attention to this. And I wonder whether
before takes over, we are so much better in really handling the side effects and infections. But we are participating in bispecific trials. Was the first one with Amgen since 2016. A couple of patients died from infection, PCP, pneumonia. I don't know. I maybe I'm too conservative, but if I would be the patient, I always, I'm in an age where I say, what would I like to take? I rather have broken nails before I have pneumonia, period. That's how I approach it. It's kind of, oversimplifying, but the infection risk scares me, to be very honest. The alternative is shorter duration. That's that we say, okay, 6 months, that's it.
Meral?
So I strongly support Suzanne's comment on infections. I have never in my life used so much intravenous immunoglobulin, until the last 2 years when we started using bispecifics. And of course, with Dara, we had similar issues, but not this much. And then that during the IMS meeting, Niels van Donk gave a very beautiful summary of how to sequence these immunotherapies. And I think if we summarize in one sentence, it says that if you receive one immunotherapy after the other one, I mean, either the bispecific or the CAR T cell, the subsequent ones' success is less. So if you want to give an order, a sequence, it's usually recommended to have CAR T first and to follow with the bispecific, but do you have the excess? And so, and regarding GPRCD, we have some experience in clinical trials, and patients get used to it and they overcome the weight loss issue. And I think the immunosuppression is more difficult to overcome unless you shorten the treatment period.
Luciano, is this your practice and this is your treatment algorithm?
Yes, I think because of one, the appeal of quote unquote one and done, but also what we have starting to learn about sequencing, we tend to use a BCMA directed CAR T first when we can. And the issues that have been brought up is not, patient fitness, access, but also disease tempo. And that's something that often gets missed in the discussion. There are some people who, it's always easier when you know the patient for some time, but some people you just cannot see, they're hanging on until the CAR T is manufactured. And those patients will end up using bispecific. We actually have had very similar thoughts that the others on the panel about when it comes to choose between bispecific. I also find that, if you look at population, but, for similar population, the rate of response for talquetamab seems to be a little bit higher, if we can go with that. And in a way, it has the convenience of being every other week from the beginning. And you have the appeal that, the toxicities are more forgiving than the infections that can be quite catastrophic. We all hope with the more proactive mitigation strategies that we all have adopted, and less frequent of dosing, those infection is going to be less of a problem, but it's nevertheless a problem. So we have, as a group, we have favor when we go to bispecific off trial to go with talquetamab first.
So you mentioned, and most of you are alluding to the issue that probably we need shorter durations of bispecific, but also maybe longer cycles at some point. And indeed, this is what was shown, for instance, in the MAGNETISM-3 trial, those patients who achieved complete remission after 6 cycles or 6 months, they were able to switch to twice monthly. And there is a trend towards having less infections. And this is the same, I think, with teclistamab, according to a poster I've seen, I think, at IHA 2023. But all of you also are alluding to IV immunoglobulins. And it looks like we're breaking the bank, not only with the cost of bispecific, but also with immunoglobulin, especially with the global shortage of IV immunoglobulin. So my question to you guys, is it mandatory to give to all of them? Are there any rules saying, well, this patient we can avoid, or we may do something like preemptive based on the IG levels, although at some point they will all get something around 0 or 1? Any practical thoughts? Because of course, in theory, we would love to give all kind of prophylaxis to our patient, you know, but at some point you have to find the right balance.
Mohamad, absolutely. That's a good question. But I would always look for the history of the patient. Was there infection in the prior history? Fourth line treatment. Fourth line treatment can be different. You know, it can be, okay, the patient started 2 days Revlimid, didn't tolerate it, and is moving on. Or the patient could be for transplant, 5 years on Revlimid, and then the next, you know, really, or DSEP. You know, I think you have to look a little bit what exhausted T cells and especially B cells. And then prior history, for instance, of, you know, pneumonia and low immunoglobulins. I think I wouldn't be brave enough to not give immunoglobulins. You know, for me, it's an order, you know, and for the patient might be a trip to the ICU, you know. So as long as I can get it, I would give it, you know.
Yeah, I totally agree with Suzanne. The last thing we want is to gamble on fatal infections. So unfortunately, the cost is a problem. And maybe that could be the way to try and figure out, are there, you know, cheaper IVIGs in the world? But so far, I would always be careful that my patient is not harmed.
Luciano?
Yeah, yes, I think the point I make is that, you know, the hypogammaglobulinemia that you see with BCMA-directed therapy is not a side effect, is a direct effect, is a on-target therapy. You know, the normal plasma. So there's no scenario where somebody stays on a BCMA-directed therapy and is not severely hypogammaglobulinemic. So we see that's why we have been skeptical of recommendations like, well, if it drops below 400, well, it will drop unless you're measuring the M component, you know. The thing I think we have to is to a little bit polish is, you know, how little IVIG, the doses are all over the place, right? We probably, you know, we might give too much for some patients. So maybe there is a lower dose that is effective and safe that can help mitigate the cost. And last, it has been said already, if you can reduce the frequency for the administration of the bispecific, we're not going to improve the hypogamma. I mean, because as long as you're working, the drug is working, you're going to have hypogamma, but you mitigate the cost, and that leaves more cost to justify the mitigating strategies.
Thank you very much, Luciano. I like your comment. And actually, by the way, just for those guys who are interested in history, what we are doing with bispecific antibodies and hypogammaglobulinemia, actually, it's a fantastic study model in theory for the so-called Bruton agammaglobulinemia. This is also known as the X-linked agammaglobulinemia, which was described by Dr. Bruton in 1952. Actually, we are simply creating a model to study this X-linked disease with our myeloma patients. I think we can learn a lot from these guys, but that was, for me, fascinating in terms of history of how you create an artificial model of agammaglobulinemia. So what about other prophylactic measures? Because we speak about IV immunoglobulins. What about cotrimoxazole? What about antibiotics like amoxicillin? What about antifungal prophylaxis? Are there any recommendations, standard of care to be used, applied when using bispecific? Because they are much cheaper than, I guess, IV immunoglobulins.
So I think all patients should have antivirals, you know, that's for sure. What we are doing, the way we treat patients more like our allogenic, you know, transplant patients. So I never checked CMV, EBV, adenovirus, HHV6, you know, in those patients. But I start to do that to have a baseline, and in case sometimes they just get, I don't know, I don't feel well, for instance, you know, and then to recheck, you know, those titers. We don't do it as of now on a regular level. We might kind of, you know, switch it, but at least a baseline level. In some patients, you know, after the data came out that the prophylaxis in multiple myeloma, when you start treatment, is of benefit, I did it for a while. Then I had 10 patients with C. diff and I stopped it, you know. I don't know. I mean, the IVIG is, I think, the way to go. Prophylactic antibiotics in selected cases. I shy away from giving it to everybody. And antifungals, I think a good clinical exam is important, you know, to ask the patient to open the mouth and look into it. You know, a lot of people don't do that anymore. I think a good clinical exam, you know, might also save some costs.
Any other thoughts on this? Yes, Hira?
Yeah, so would agree. You know, I think the paper put up by the IMWG consensus is actually also helpful because these are somewhat newer therapies for us, and especially for some community folks. So again, I'm doing IVIG for everybody. I know it's a huge cost, but again, right from the start, I'm doing it for everybody. PCP prophylaxis, antiviral, and then again, no antifungals routinely on my end. I do sometimes do antibiotic prophylaxis just for a few weeks as we're getting started based upon a previous history of infection. So pretty similar to the panel. You know, as we again move on to fixed duration treatment, it will be interesting to see what we do with IVIG. But for the time being, like everybody else, I am a bit too scared of the infections.
Excellent. So the culprit when it comes to infections is about T-cell exhaustion, at least in part. And we have one question from our colleagues attending is how can we assess T-cell exhaustion and maybe one day be able to use it as a sort of a biomarker to guide our treatment or prophylactic approaches? Irene, what do you think?
Yeah, I totally agree. And it's an excellent question. And we do need better biomarkers to guide therapy in general for us. And single cell sequencing or flow cytometry for the types of T cells you have is not only guiding you of, you know, who should be on which therapy, but it's decide when to stop therapy. I think the more we use our biomarkers in the right way, the less we will expose our patients to drugs that may be ineffective for them. And we're talking about millions of dollars of drugs. So it is our duty, I think, to develop better biomarkers, and that's better genomic markers for our patients instead of FISH, but also better immune biomarkers to predict who will respond to therapy and who will not. And we're getting there. It's not that far from here.
Excellent. Thank you very much. So I'll push it a little bit forward because we have a few questions about the issue of combining bispecific with monoclonal antibodies like anti-CD38 or maybe other agents like IMS, cell modes, but also combining two bispecific. It's sort of like, you know, an artificial quadrispecific. Also trispecific are being developed. I mean, they are trispecific. So, and I was impressed by some of the results of some of these combinations, like 100% response. Obviously, safety is still work in progress, I would say. What are your thoughts and where do you view the future here? Suzanne?
Yeah, I think it's a little bit too early and it's a lot of speculation. The combination sounds promising, but what in case we use bispecific early on in patients, newly diagnosed patients in combination with IMiDs, you know? So you have healthy T cells and you activate the T cells. Will you have the perfect storm? In some patients where you have ICANS and CRS, we saw that in some of the amyloid patients who have much better T cells because they have less treatment, and we used teclistamab and we saw, I would say, maybe a little bit more ICANS, you know, and CRS, I was surprised. So I think it's a lot of speculation. It's a little bit too early, and we just have to do that step by step. But very much interesting is really the CAR T cells that really are bispecific, have two targets. You know, I think that's a very interesting approach.
Do you share the
I
same
think,
opinion, Luciano?
yes, I think I believe it was Sagar that was making this analogy that is like the old days of tuberculosis or HIV, that you if you got to target multiple things to overcome eventual resistance. I was a bit surprised really with the redirect trial in a good way. I think if you think of how I see what has changed the most in the last year, that I used to perceive failure of bispecific mostly as immunologic failure. And I think now we're learning that a lot of that, perhaps not, if not most of it, is actually a target failure. And I think the redirect trial exemplified this very well. When you tackle two targets simultaneously, you get much better responses. But also what we're starting to come up from the genomic studies on those patients showing that dropping the target, particularly GPRC5D, is quite common. So at least in theory, if you are going after two targets, you greatly minimize the odds that the cell will concomitantly develop resistance to both, at least in principle. So I think we're going to be seeing more and more of that theme in the years to come.
Excellent. So that brings me to one. Oh, sorry, Meral, you wanted to add something.
Yeah, I wanted to mention about a study by Niels van Donk showing in vitro the synergism between daratumumab and the bispecific. So there was a very good comparison. Without the dara exposed, the bispecific efficacy was less. When those patients who were exposed to dara, the in vitro data showed that there was an increased efficacy. So I think with dara having multiple effects, so in the era of immunotherapy, we are not just talking about the target, but we are also talking about the accessory cells, the microenvironment, other cells which are involved in the immunological recognition and the effector effects. So the combination therapy may evolve in this sense.
Okay. Can I ask you one question, and before we move to the last concluding remark? A real-life case of a patient who received CAR T cells, anti-BCMA CAR T cells. The patient progressed after, let's say, 13 months, and you want to give a bispecific, and obviously our approved bispecific and the most popular for the time being, at least in Europe, are teclistamab and elranatamab. So should we check for BCMA expression if the patient has relapsed after CAR T? So how do you handle this if you want to use something directed against BCMA?
Yeah, I think it makes sense, but I think biologically it makes sense to check, for the target, for T cell exhaustion. But practically, I don't think we have the tools as of now to do it, for all of our patients outside of clinical trials.
Okay.
Yeah, but we definitely should be doing it. I mean, if they have biallelic deletion of BCMA, we don't have the target. Why are we treating them with another BCMA? And that's critical. And the tools are there. We do need to develop them. I mean, I agree with Suzanne. We don't have them clinically. This is unfortunate, and we do need to develop them urgently.
Yeah. I would say, Dr. Bayless again showed lovely data and his lovely publications kind of around this. Even between different types of bispecifics that are BCMA targeting, there probably are going to hopefully be future tools for us to see how we can sequence.
So I do not disagree. I would only, I think, make a very important distinction for those who were watching. I think we all agree that we need to develop those tools and bring those tools to clinical practice. What I worry about is people, doing, their run-of-the-mill immunohistochemistry and trying to base therapy based on that. I think the fact is none of those therapies were developed with a target validation, and we don't know the performance of those tests. You might, maybe too many false positives, too many false negatives. And a lot of the mutations are not total losses. They are mutations that affect the domain for one particular antibody, but not for the other. So your immunohistochemistry may still pick up the tag when it's not there, and vice versa. But the reality is, those patients who have a long response after a prior BCMA CAR T, the majority will still have the target, and the proof of that is that the response rate for BCMA-directed bispecific on those populations is very similar to those who never received a BCMA-directed CAR T before.
Excellent, fascinating debate. As I promised in the introduction, I'd like for the last 3 minutes to ask Suzanne to give us a summary about state of the art of management of amyloidosis. Where do we stand?
So first of all, if you have patients with lambda MGUS, make sure that you don't overlook AL amyloidosis. Symptoms can be, I would say, not that obvious. Carpal tunnel syndrome, orthostatic hypotension. It's really important that you do not miss your patient who shows up with low voltage and heart failure, etc. It's very embarrassing. It happened to all of us, but I think that's number one, really look out for amyloidosis. Number two, treatment is pretty simple. We only have Daracibody as the only treatment that was tested in a randomized clinical trial. Make sure when you have advanced patients that you decrease the dosage of the steroids, not well tolerated in our patients. So Daracibody, and then the first relapse, make sure that you check for translocation 1114, venetoclax. If it doesn't work in multiple myeloma, it works in amyloidosis. Single agent 400 milligrams is sufficient. In relapsed amyloid patients without translocation 1114, a little bit more difficult. Maybe you go back to Daracibody. I usually try to avoid IMS because it leads to worsening of the heart failure. Also, carfilzomib not very well tolerated. So you might run into some problems. What do you do what do you give in case of relapses? We did teclistamab, couple of cases successfully. So even teclistamab might be a good approach. And transplant, the role decreases. The role of transplant is decreasing in AL amyloidosis because so many patients go into deep remissions, MRD negative CR, just with Daracibody, but we still do that in certain cases when patients have a good cardiac function and are not going into complete remission. And last but not least, anti-amyloid antibodies. We have 2 right now in clinical trials, NeoD001, Procina from Procina, and then 1104 or KIL101 from AstraZeneca. The trials are ongoing. But it's too early really to see results. I want to point out that the Procina antibody failed originally in earlier stages of amyloidosis, but there was just a blood paper publication that in stage 4 amyloidosis, there was an increase of the overall survival when the anti-amyloid body was given. Of course, we need to reproduce this in large clinical trials, and then we will see. I think if those trials are negative, we are done with the anti-amyloid antibody in light chain amyloidosis. But let's see.
Wonderful. Thank you so much, Suzanne, for this fantastic summary in less than 3 minutes. You did a great job, and I'm very grateful to all of you. It's more than 31 minutes past the hour, and we had really a fantastic, beautiful discussion. I think we can discuss for hours and hours about all the exciting developments we see in myeloma these days. But I believe this IMS 20th annual meeting held in Athens in Greece in September 2023 was another huge success, thanks to the leadership of the IMS, thanks to the colleagues from Greece, but also thanks to the distinguished faculty who designed the program and run the meeting. And you guys did a great job summarizing the key points and sharing your knowledge and experience. On behalf of all the IACH community across the globe, I thank you all for participating. And wherever you are, as we say, please stay safe and keep well. Thank you very much. And this broadcast will be available on demand within 24 hours on the IACH website, clinical hematology.org. Thank you very much.
Thank you.
Thank you all.